Good afternoon, and thank you everyone for joining today's webinar. Before introducing our presenter today, just a couple of notes. We're going to be recording the webinar today, and we'll make it available on our website, www.pulse.org, for viewing later. If you have any questions, please just enter them into the chat box, and we'll address them throughout the webinar today. Our presenter today is Dr. Kenneth Brummel-Smith. He holds the Charlotte Edwards McGuire Professor of Geriatrics at Florida State University College of Medicine. Dr. Brummel-Smith has been a leader in geriatrics for 30 years, currently chairs the Alzheimer's Research Advisory Council for the Florida Department of Health, and has done research on the use of the physician orders for life-sustaining treatment form in advanced care planning. His presentation today is Frailty and Mortality and how they are linked. And on that note, Ken, the audience is all yours.
All right, thank you very much, Hannah. I'm glad to be here and glad all of you have joined us today, and I welcome your questions and challenges, so don't hesitate to get something down if you have a question that comes up. We're going to be talking about the link between frailty and mortality, and this came out because of some personal experiences here in Florida. So the objectives are to define frailty, to name at least 3 models of frailty, and there actually are a number, to discuss the risk of mortality based upon frailty status, and then to finish up with discussing a person-centered approach to pulse decisions in persons with frailty. So some background. If you go to the National Pulse Paradigm website, you'll see in one section that it says pulse is for, quote, only individuals with a serious illness or advanced frailty near the end of life. A few states have but very few states actually have on their pulse forms anything specifying advanced illness or frailty. And that's because really that ought to be in the discussion between the provider and the patient as they're deciding whether a pulse is appropriate for them. And in fact, some people feel that ethically it would be inappropriate to put down a specific reason for completing a pulse on the form itself, whereas other people feel that perhaps it should be on there. But most states do list medical frailty or advanced frailty or some other term like that in the educational guidance as to who might be an appropriate candidate for filling out a pulse form. But there's been some opposition in some states to the use of frailty as an indication for using a pulse form. Some of this has come from Catholic conferences where in a letter from the Florida Conference on Catholic Bishops to us, to our state pulse task force, they stated that the use of frailty was vague and confusing and that there was no direct relationship between frailty and longevity. Also, as you know, nationally there's been some objection to the use of pulse from some disability rights groups, and that's partly in relationship between the association between frailty and disability, which I'll talk about. So this interested me personally to look at the literature and try and find out more about what the relationship between frailty and mortality might be. But before we even have that discussion, we need to be sure that we're on the same page regarding frailty. And this is somewhat difficult. Frailty as a concept is different than our normal concepts of disease. And personally, I think it's a really fundamental geriatric concept, and I'll try and make an argument for that. But this is, I think, a useful definition that came out of the Frailty Consensus Conference that the American Medical Directors Association held, and it was published by John Morley. And it states that frailty is a clinical state in which there's an increase in an individual's vulnerability for developing increased dependency and or mortality when exposed to a stressor. So in other words, frailty isn't a disease. Frailty is a clinical syndrome. It's not the same as disability, but it does confer increased vulnerability to stressors. And I'll talk a little bit about it. There unfortunately is not a whole lot of research in this area, but it may be reversible, but it also may not be reversible. So one of the problems with...
Ken?
Yes?
Ken, this is Hannah. Sorry, I just wanted to interrupt just for a moment. I want to make sure you were able to advance the slides, okay? I just noticed on one of our
I'm sorry, I was advancing the wrong slide. So
just
let
make sure
me
you can
go back.
do that.
Yes, that would have been really smart to do that. But let's see.
I think
okay, it is working.
There
Objective.
we go. Okay, perfect.
Yeah, thank you for interrupting me.
Okay, thank you. Yep.
Here's the background I mentioned about with advanced frailty. I'm really sorry for that, but I'll use the right one now. Here is the reference to the Catholic Conference and the definition, which we're on right now. So I think personally one of the problems with the definition is that frail is a regular word. It's like depression. So those of us in the healthcare field use depression as a very specific clinical term, but everybody uses depression for other reasons, like I feel depressed that my team didn't win this weekend or whatever. So that makes it somewhat difficult. It's also, as I said, not a disease. It's a syndrome. And I think a lot of people don't really understand a syndrome and how a syndrome can be really as dangerous or perhaps even more dangerous than a disease. For example, if you think of heart failure as a disease, it actually is not. It's a syndrome. It's a collection of symptoms, and it confers pretty high risk for mortality. Another example in geriatrics is falls. There isn't really a disease called falling, but falling is very risky, and in fact is probably the fourth or sixth, depending on which list you look at, leading cause of death in older people. In fact, it has a higher death rate than diabetes does. So syndromes can be very worrisome in older people especially. And that's something that lots of lay people don't know, and many physicians and other healthcare providers may not be familiar with the idea. So really you have to think of frailty as like a risk factor. In a way, it would be like a positive treadmill test. You know, under stress, the person who has atherosclerotic heart disease and problems with their arteries of their heart is going to show some types of problems on a treadmill test that someone who doesn't have that won't show. So it's an indicator of being at increased risk when some type of stress is applied. This is from the original research done by Linda Fried, who really established this concept of frailty, and she showed how there is an overlap, but not complete overlap, between frailty and disability and comorbidity. And as you can see, we won't go through the exact amounts because different studies have shown different amounts of overlap, but as you can see, there are definitely people who have multiple comorbid conditions, like heart disease and lung disease or dementia, who are not frail and who are not disabled, but there also are people who are disabled who are free of comorbid conditions and free of frailty, and there are frail people who don't have disability and don't have comorbidity, and then of course there's a lot of overlap. And our big concern in dealing with PULSE patients is probably in the groups that have the overlap because they have the highest risk, as I'll show you. So there are a variety of frailty models, and I'm not going to go through all of these. Many of these have been looked at primarily in research settings and not so much in clinical settings, but you'll be hearing some of these, particularly the cardiovascular health study, the study of osteoporotic fractures, the FRAIL model, and the FI, or Frailty Index model. Part of the problem with reading the literature is FI can be used for frailty indexed or for frailty indicator, and so you have to be careful as you're reviewing the literature. And that same reference I gave you earlier from John Morley about the Frailty Conference has the exact references to each of these models if you care to look at it. So we know that frailty from a large number of studies is a pretty common condition. Prevalence means what percentage of the population out there have it right now. And Collar did a systematic review and found that in people over the age of 65, the prevalence of frailty ranged from 4% to 17% with a mean of about 10%. And women were almost twice as likely to have, the prevalence was almost twice as high in women as it was in men. And importantly, that it markedly increased after age 85, with as many as 45% of people meeting criteria for frailty using one scale or another. What frailty isn't, however, is important to realize. So as I mentioned before, with people with chronic disability, and this is why I want to make sure that we address the concerns from the disability rights groups, that many people with chronic disabling conditions are not frail. They are definitely not sick. And many who are frail do have ADL and IADL disabilities. So that's activities of daily living, like bathing, walking, transfers, toileting, eating, dressing, or instrumental activities of daily living like shopping, cleaning, cooking, using a telephone, managing their money or their medications. Also, it isn't the same thing as sarcopenia. Sarcopenia is muscle weakness, and whereas most people who are frail have some sarcopenia, not all people who have sarcopenia are frail. And that's because sarcopenia is primarily a single problem, muscle weakness, whereas frailty is multifaceted, as you'll see from the different models that I'll be discussing. And then finally, it isn't the same as multimorbidity or comorbidity. This problem is much more common than frailty. It may affect up to 75% of people over 65. The average number of comorbid conditions in people above 80 is 6. So it's just an extremely common problem, but it doesn't necessarily mean that the person is frail. So you're probably wondering, can frailty be reversed? And unfortunately, because frailty is a relatively new concept, there haven't been a lot of studies that have specifically looked at interventions for frailty. About the only area where we do have some pretty good studies on that is with the use of exercise interventions. This, in fact, is the only intervention that's been specifically studied in frail persons. However, the consensus conference felt that these other 3 interventions, such as improving the nutrition of the person, making sure that they didn't have vitamin D deficiency, and making sure that they didn't have the negative results of polypharmacy, multiple drugs, that those probably could help reverse frailty. But as I mentioned, they haven't been prospectively studied. One concept I wanted to get across about polypharmacy is that although often you'll see in the literature it's designated as a certain number of drugs, sometimes 4, sometimes 5, it really isn't that helpful to think about it in terms of number of drugs, but rather to think about it in terms of drugs that are not doing what they should be doing or causing adverse problems. So a person could have polypharmacy with 2 drugs if they're not indicated and they're causing problems. So how is frailty determined? The first one that was developed was Linda Fried's work in the cardiovascular health study, and she used 5 criteria. Weight loss, which was not, the person wasn't trying to lose weight, and it had to be more than 5% in the last year. A feeling of being tired all the time, or most of the time, I mean. A low score on the Yale Physical Activity Scale, poor grip strength, measuring it with a dynamometer, and slowness, difficulty walking a quarter mile. And she termed that if a person had 3 or more of these, that indicated the person had what she called a frailty phenotype. The problem with this screening mechanism is that it's kind of difficult to use clinically. Most offices don't have hand dynamometers. Access to the physical activity scale is sometimes hard. So I would say that it has not received a large use in actual clinical situations. It's still very commonly used in research situations. Other screening models include these. You can see the study of osteoporotic fractures is a simpler one. Again, it has 5% or more weight loss in 1 year without trying to. Inability to do 5 complete chair stands in 1 minute. And having when asked, having whether they have a lot of energy, the answer being none, or they feel like they don't have a lot of energy most of the time, then that's a positive score. The frailty index is from various formats, from 25 to 40 different items, and it has been validated specifically in an African American population. And then the cumulative deficit model is 48 different deficits. The latter 2 are very good for research purposes, but because of the great number of items, they haven't been used a lot in actual clinical situations. They've been used in clinical research, but they aren't used regularly in clinical care. I personally like the simple frail scale. This was developed by John Morley, and it's a series of 5 questions where you ask the patient, are you fatigued? Can you walk up 1 flight of stairs? Can you walk 1 block? Do you have more than 5 illnesses? And have you lost more than 5%? Again, weight loss being a really important criterion. And you add up the scores, and you can see the scale there below, so that if a person scores 3, 4, or 5, then they're in the frail category. We use this in our geriatric assessment clinic for all patients. So the question is, does frailty affect mortality? And what I'm going to present now is multiple different studies that look at mortality as one of the outcomes. Now, I encourage you, if you have an interest in frailty, to get the references that are at the bottom of each of these slides, because it's a lot more important than just mortality. And a lot of it has to do with other types of adverse outcomes, like nursing home admission or other complications than just mortality. But for the purposes of this webinar, we're going to be focusing on mortality. And multiple studies now have shown that various different measures of frailty show that persons who score in the frail categories have higher mortality than their non-frail, or in some studies they're called robust persons. What's interesting, like I showed you in the simple frail scale, where there is an intermediate category, sometimes called pre-frail, that also confers higher mortality, but some studies have not shown that, and in all the studies that have looked at it, where there is a higher mortality, it isn't as high as when they're in the frail group. So back to Fried's original work, you can see on this graph, can you see the arrow, Hannah, as I'm moving this now?
Let me see. Can you do it again?
I'm just kind of moving the arrow around.
Or we don't see it.
You don't see it, okay. I'll describe it.
Mm.
So the vertical axis is 100% are alive, and you can see it goes down to 0%, and then the horizontal axis is months after the study entry. And the lower mixed long and short dotted line is for the people who are frail. And you can see if you look at 24 months down on the horizontal axis that after 2 years about 90% are alive in the frail group compared to almost 100% in the non-frail group. After 48 months, then below 80% are alive, maybe 77%, and at 72 months, probably about 70% are alive. So over a period of 3 years, about 30% of the people in her population died. This was a study that compared the study of osteoporotic fractures frail scale to the cardiovascular health scale on the same population, looking at the predictability for death. On the vertical axis, there's something called HR, which stands for hazard ratio, and it goes up to 4, so 4 times the risk of dying over the time period. And this time period was 3.2 years. And you can see that using the study of osteoporotic fracture scale, there was about a 2.5 times increased risk of dying over that 3.2 years, whereas the cardiovascular health study scale showed the population to have a 3.5 times risk, and both of these were statistically significant. The study of osteoporotic fracture scale for pre-frail was 1.3 times risk, but that was not statistically significant, whereas the CHS scale for pre-frail showed a 0.77 increased risk, and that was statistically significant. This is another study looking at frailty and mortality outcomes specifically in people who were cognitively normal. And some people have suggested that maybe frailty is a surrogate for underlying dementia, and this was trying to answer the question, is it dementia or is it separate from dementia? And it appears to be separate. This was using the scale called the Frailty Index. And you can see, again, the percent alive is on the vertical axis, and the number of years is on the horizontal axis. And if you look at the different lines here, the bottom 2 lines, 7 and 8, refer to the frailest females for 7 and frailest males for 8. So whereas I said that frailty was more common in women, it appears in this study at least to be more lethal in men. And you can see that by year 3, in the men, more than 20% of them had died. And by year 8, 40%, only 40% were still surviving, so 60% had died of the men. This is a study that compared 4 different frailty scales on the same population. The frail scale, as I mentioned, the one that we use in our geriatric assessment clinic, the osteoporotic fracture scale, the cardiovascular scale, and the frailty index. And you can see in this study, the frail scale performed the best in terms of predicting who would be likely to have high mortality with an increased risk of almost 3.5 over a period of 9 years. Now, that's a long time, obviously, and so that may not be that specific to our pulse discussion, but still it does highlight that frailty is clearly a mortality risk factor in this group. The asterisk refers to it being statistically significant p less than 0.001, and the only ones that actually had that statistical significance were the Frailty Index and the Frail Scale. This is a study from the Canadian Study on Aging, and again, it has multiple different levels. They were using something called the Clinical Frailty Scale, which is similar to the Frailty Index, and you can see that using this scale, then the probability of survival to 60 months, months is on the horizontal axis, was way down to about 0.4, so 60% probability of dying during that time period. Again, though, this is 5 years, so probably that isn't directly related to our discussion around pulse. But even at 2 years, you can see that 25%, and 25% is a pretty high mortality rate. This is an interesting study looking at another model called the cumulative deficits model. And again, these are different levels of frailty, and you can see that for the frailty level at 9, the highest level of frailty, again, over this period of 50 months, about 25% had died. I just saw that a question about the copy of the presentation, and yeah, we can make I'm fine with sharing these slides afterwards. This is a study that looked specifically at African Americans. It was a period of 9 years, and you can see again, we see that relationship between frailty and mortality, with the mortality odds ratio being almost 4.5 for people who are in the frail scale, in the frail category, and this was using the Frail Scale by John Morley. Now, another interesting thing to think about is people don't just become frail suddenly. It's a progressive problem in many cases, and so people have been looking at what happens to people over time who are scored in the frail group. And this was a really interesting study looking at what they called frailty trajectories. And so they found, they looked at 3 groups of people, 60 to 69, 70 to 79, and 80 to 89, and they followed them over 3 years. This was in the Rush Memory and Aging Project in Minnesota, involving 16,000 persons. What they found was very interesting, and that is that if the frailty is rapidly increasing, then they have an even greater risk for mortality. And interestingly, if that's occurring in the younger of those 3 cohorts, that their mortality was higher than for the older persons. Here you can see the 3 different trajectories, and in the younger cohort, over time, naturally, because they're younger, not as many died as in the older cohort. But if you look at the actual trajectory, you can see that the risk was much higher in the younger group than it was in the higher groups. And these were statistically significant differences. So probably this fits with our standard experience in medical care, that generally young people who are rapidly declining often have severe complications, and older people who are slowly declining may have less severe risks. This was an interesting study looking at frailty in cancer. Cancer treatment has had a lot of criticisms, because sometimes people believe that oncologists are treating only the cancer and not the patient. And I think that I've seen a real change in the last 5 years or so among oncologists in being much more open to measuring functional abilities and paying attention to patient-centered decision-making. So I do think that there's a change going on within oncology care, and this is, I think, a good example of that. So they looked at how many people who've had cancer and survived have frailty, and they found that it was very high. Now remember, I said that it was about 10% for the general prevalence, but this was at an older age group, and the prevalence that I quoted at 10% was for people over 65, and here the average age was 72, and they followed them for 11 years. What they found was that the survival was much higher in people who were not frail, who were robust, compared to people who were frail. And you can see a pretty marked difference in terms of years in the people who were frail compared to the, or not frail compared to the frail population. So it's probably not enough just to measure the cancer status of the person, but in this, the mean term, the 2 years, as you can see for frail people, was around 2 years, maybe 2.5 years, which is interesting because that's similar to the mean survival for many long-term nursing home residents with or without cancer. So I think that there's good evidence that frailty increases the mortality risk, and that is something that is measurable in a clinical situation, and it's something that may be reversible but may not be. So the real question comes down to, if this is a risk for death, how do people want to make decisions about their own care regarding the future? And this is where I think the concept of person-centered care and having an in-depth discussion with the person about their wishes and their goals is so important. So we have to remember that there is a fundamental ethical principle that says that each person has the right to choose their own medical treatments based upon the principle of autonomy. And although we would like to help people as much as possible to benefit them, the principle of beneficence, we have to remember that a benefit is a perception by the patient. It's not an objective, externally measured viewpoint. It's something that the person has to perceive as benefiting them. We also have to realize that frailty interventions are difficult to achieve. Exercise is likely to be the most efficacious intervention for frailty, yet there is limited evidence that interventions into exercise are adopted by people. In fact, the U.S. Services Preventive Task Force for quite some time said that exercise prescriptions did not show evidence of having benefit, primarily because people were so low on the take-up of those exercise recommendations. And this is, for anyone who knows motivational interviewing, the status quo is always, almost always preferred over doing something different in your life. And if you're frail, going against the status quo is difficult. So we have to realize that although there may be ways of reversing frailty, we may not be that successful in helping people to make that change. This brings up the idea of how patients choose to gamble. Every medical intervention is a gamble. There's benefits that we hope we'll see, and there's risks or burdens that we hope we will avoid. This has to do a lot with the person's personality, their life view, and involves things like their self-efficacy. How strongly do they believe that they can make a change? What support systems do they have to make those changes? What kinds of comorbidities do they have that might impair them from engaging, for instance, in an exercise program? And that isn't even addressing the kind of elephant in the room about cognitive impairment. One of the things I think that's a problem with almost all the frailty studies that I've seen, except for a few that use the multifaceted measures like the Frailty Index, is that they rarely measure the person's cognitive status. And then we also have how we think about risk. In the medical model, especially physicians, like to think that we can make predictions about lifespan and risk based upon physiology. I think that the original criteria that were used by the hospice system, for instance, for determining 6-month prognosis were fraught with problems because they tended to be very physiology-oriented. Things like the forced expiratory volume of the lungs in 1 second or the ejection fraction of the heart. Yes, these things are associated with mortality, but it's difficult to make accurate predictions about prognosis based solely on physiologic predictions. So it may be that a person, for instance, with a low ejection fraction and a low FEV1 may consider that their gamble to be worth the risk to have invasive treatments, whereas another person may think, I don't even want to take the chance that if I do this intervention, I might end up on a ventilator and not be able to get off of it. So I have a personal experience in taking care of an elderly patient who was 96, and she had been a physician, and she was very adamant about not wanting to take the gamble of any treatment in a hospital because she was just afraid once things got started that people wouldn't be able to stop. And I remember in her values discussion, which we held in her house and actually videotaped it because she allowed us to videotape it to be able to use for medical student education. I remember when asking, what's most important to you as you think about your own death ahead, she said to die in that bed, and looked into her bedroom. And then later when she became very sick in her home, and I went to her house and saw her and examined her and thought, she could be having a heart attack, she could be having some type of vascular problem in her belly. And I said to her, the only way I can really tell this is to go to the hospital and to do some tests. And she said, no way, I am not going. I don't want to have something happen, and I'll either get better or I won't. And she ended up dying about 5 days later in her bed, in her own bedroom. So she was unwilling to take a gamble of being exposed to those sorts of things. I still don't know exactly what caused her death. She definitely had a pulse form. But I do know that what happened was that her gradually increasing frailty had changed her view of the types of gambles she was willing to take. So if we think about things in terms of frailty and the disease orientation, frailty really fits with the geriatric viewpoint of health and illness because it really deals with a person's functional abilities and their own perspective of quality of life compared to diseases, which we usually deal with in terms of physiology and those sorts of measures. So sure, it's true that as people get older, both total and disease-specific mortality risk increases, but the relative risk of death due to particular causes declines with advanced age. In other words, it gets harder and harder the more advanced age the person is to determine exactly what it is that's causing their death. This is why I don't really like the disease orientation in terms of making that decision about pulse, because it has much more to do with how the person wants to live the rest of their life than it is to do with the type of disease treatment that they're receiving. So many people with advanced age live with serious functional deficits and with frailty, and this affects their quality of life. And we know from multiple different studies that the sense of quality of life tends to drive people's decisions much more strongly than the presence or absence of diseases. I wanted to familiarize you with a really interesting study, and I'm going to show you a slide from it, but I really encourage you to read this study that really looks at maybe we need to redefine the whole idea of health and well-being. Because in our traditional model, we focus on these diseases. You know, what ICD-9 or ICD-10 code are they? How many do they have? What treatments are they receiving? But we often forget that the psychological and the social and how a person can sense things, whether they can feel safe walking, whether they have functional problems, those are often not even measured in medical situations. Yet it's these factors which more strongly affect independent living and quality of life and a gratifying life than those diseases do. So what they did was they looked at a huge number of patients. Let me get the exact reference here. And I know this is a little hard to see, but I wanted to show you is they looked and tried to categorize in I didn't write it down, but these were tens of thousands of patients in the Haynes study. And what they looked at was if we modeled the disease orientation, those are the people basically with the yellow section. So you don't really need to see the individual ones, but just see the yellow sections. Then what would their mortality rate be? And then they looked at, and then the green means they don't have those problems. And so most of the medical conditions are all on the top columns or rows of the graph there. The red are a lot of the other, the bottom section, the bottom rows are a lot of the sensory and psychosocial and psychological and social and functional aspects. So they added those in there. And you can see that using that model, a huge increase in the risk of death over time was seen. So 44% of people died over the study's time when the psychological and the social and the functional categories were brought into the picture. Whereas looking at it from a pure medical model, only 14 to 19% died over that 5-year time period. So we can fool ourselves if we focus too much just on the medical and don't bring in this important area of the psychological and social and functional aspects. So in summary, the important thing to recognize is that frailty is a clinical syndrome that can be measured. It's common, especially after age 85. It may or it may not be reversible. It does reduce longevity and it increases mortality. And that we ought to use person-centered values to guide medical decision-making and all interventions, especially in this age group or this in frail persons, because they may choose to gamble differently with medical interventions than you or I would choose. So with that, we still have some time to try and answer questions if you want to type any questions in. Or, Hannah, I don't know whether they can call questions in. Is that available?
Yeah, in this case, the only way to do it would be to type your questions in. And
okay.
I haven't seen any others come in, so yeah, we can just.
Okay.
And yeah, we'll definitely have your presentation up on the National Pulse Paradigm website, so the recording will be available for those who didn't get to listen in today. Oh, and some questions are coming in a little bit here, so let's see.
So here's I see a question regarding the surprise question. So the surprise question is, would you be surprised if the person died within a year? Well, clearly, if a person has, if you wouldn't be surprised if they die in a year, then that would be a person who is much more frail than many of the studies that I showed you. The time period that most of the studies were in was from around 2.5 years to 5 years, and a few out to 9. So I think advanced frailty is another way to think about it. So it would be a higher score, for instance, on the frail scale. But the other thing we know from the pulse literature is that many people who choose to complete a pulse form are nursing home residents. And I just heard that the latest figures on average life expectancy for permanent long-stay nursing home residents is 18 months. So, I don't know whether it really makes a big difference, whether it's 12 months or 18 months or 2.5 years. My feeling is that when you're in that group of people where there is a shortened life expectancy, you're dealing with a group of people who may have very different ideas about how they want to gamble with medical treatment, and so an in-depth, values-oriented pulse discussion is important. Here's another one. Are there validated prognostic scoring systems including frailty and other factors? There are, but not specifically around the score of frailty as far as I know. The University of California at San Francisco has a wonderful website, eprognosis.org, and there are multiple scales on there that have to do with 1 year, 3 year, 5 year, 7 year, and 9 year predictions for prognosis. Most of those don't specifically include a frailty measure. They use kind of surrogates for frailty measure, which are functional status measures. But some do include ones, but I would take a look at that. Here's another question about using a frailty measure on persons younger than 60. Theoretically, age doesn't make a difference on the frailty scales. I'm not aware of any frailty studies that have been on the younger age group, but I would think theoretically the concept of frailty wouldn't be different, but the prognostic indications for frailty may be. Although, as I mentioned before, the one study that has been done in the 60 to 69 age group showed that the only thing that made a difference in them, they had a lower rate of mortality than the older age frail persons, but if they had a more rapid increase in frailty, then they had a higher death rate. So in that young age group, it probably has more to do with the frailty trajectory than the absolute amount of frailty. Here's a question. So in New York, with the MOLST program, they use the Canadian Clinical Frailty Scale. That was one of the ones that I mentioned to you. Yeah, so I think I'm not exactly sure what the statement is saying, but that the combination of using the frailty scale and talking about prognosis along with the surprise question helps to illuminate the discussion around MOLST in New York, which sounds like a very good type of intervention.
All right. Great. Well, thank you so much. I don't see any other questions here, so there's another one that just came in. For children, our pediatric palliative care specialists have recommended using the modified Lansky Play Performance Scale.
That's good. Goes to that earlier question about before age 60. So it's called I don't know that particular scale, called the modified Lansky Play Performance Scale. I'll have to look that one up. I'm going to write it down right now so I don't forget to do that. Well, anything that measures play is probably a good idea.
All right, great. Well, if anyone else has any other questions or whatnot, they can certainly send me an email, hannah@pulse.org, and we'll make sure and get your presentation up on our website. And yeah, thank you so much for your time this afternoon, and it was really great, interesting presentation to listen to, so thank you.
Okay, thanks. Bye-bye.
Right. Take care, everyone.